We're recording, and I will share the screen and we can get going.
Okay, Fernand, give us the first aliquot.
Okay, it's a 60-ish-year-old male coming with progressive dysphagia and adenophagia. This has been dysphagia for solids and liquids, progressively worsening over a few months. He feels that food gets stuck in his chest, and he has some adenophagia with the dysphagia and weight loss.
Why don't we stop right there, because this, even though this doesn't have to do with labs, this is a really important differential, and I think having a quick discussion of that differential before we get the labs will be worthwhile. So Sherry, why don't you tell us your thoughts from that brief history, which I thought was really well stated.
So when I'm thinking about dysphagia, I look at whether it's liquid or a solid problem. And if it's only solid problem, usually there might be a structural things that's going on, like a mass. But if it's involving the liquid, then I'm thinking more of maybe a motor problem, like a neuromuscular problem that the patient are not able to swallow. And this patient also have weight loss and adenophagia. So this to me sounds more like maybe some inflammatory syndrome that's going on. Either it's an infection that's causing pain in the esophageal area, or maybe even a cancer malignancy. And the weight loss.
Okay, well, go on. I'm sorry, I interrupted you.
Oh, that's okay. And the weight loss, it can be the patient not being able to intake enough calorie, or it might be another inflammatory syndrome going on that's causing the weight loss. That's all.
Great. Do you have anything to add to that, Sandkalp?
Yeah, I agree with basically all of what she said. I think the fact that the patient has adenophagia kind of goes against a diagnosis of malignancy. Even though, like, late stages, if you have some nerve involvement, you can have pain with swallowing. But yeah, on the differences, I would mostly think of a motility disorder. And then looking at the patient's age and some weight loss history, I would also be concerned about some malignant cause as well.
Yeah. So Fernand, did the liquids and solids come on at the same time, or did one come first and then the other?
I do not know the specific answer to this. At the point when I saw him, it was both.
Yeah, because sometimes with obstruction, you do get liquids later on. So just dysphagia and weight loss. So we always think about cancer. So we would ask whether he has risk factors for squamous cell or whether he has risk factors for adeno. But we also have to think about all those other things like webs, like stricture. What if could this be? You can certainly present like this with esophageal stricture, and that might also give you adenophagia because you'd have really bad reflux. So we have all those things. And somebody in the chat, I was really pleased to see somebody put achalasia in there as a possibility, because although I think the adenophagia is harder to explain with achalasia, but that certainly will give you both solids and liquids. But they usually will say that the food sits right there at a certain spot. So that puts that a little bit lower on my list. Did we do okay so far, Fernand?
I'm sorry?
Did we do okay so far with our initial thoughts?
Oh yeah, great approach.
Okay, so let's see what happens next.
So he also added that he has been having some pruritus, diffuse pruritus, with some skin lesions, like nothing really specific, just probably related to some small papules that are non-specific. He usually lives in Florida, but he was recently visiting New York. When family saw him, they felt that he's really sick, and they sent him to us. And this is where I can give you more history, more history from the past. So he usually does not see doctors. He is known to have high blood pressure and BPH, and that's basically it. I'm not aware of any major surgery. He said he does not smoke. He drinks occasionally, does not use drugs. And I'm not sure what his occupation is.
And he doesn't have a history of reflux.
Not that I know of. I mean, he doesn't take medications for that. He did not mention that he has reflux.
Okay, just because we're sort of going down the esophageal route, what cancer is very unlikely in this guy? Which of the esophageal cancers, Sankalp, is very unusual?
I would say that the squamous cell cancer would be unusual in this person because no smoking history, and typically in the US, adenocarcinoma is more common than the squamous cell. So based on that as well, I would think that that's unlikely.
Right. And the adeno, which is usually associated with reflux.
Esophagitis, yes.
Yeah. Plenty of people show up with strictures or adeno without a known history of reflux. It's interesting when you look at that, the symptoms don't really correlate with Barrett's esophagus and with strictures. And so we still have to keep that as a possibility, but I think it's a little bit less likely that this is esophageal cancer with that history we got. We got to have some labs pretty soon. So why were you called to see the patient?
So I was called because of the labs, and our patient had thrombocytopenia.
Okay, can you give us the numbers?
Yes. So the thrombocytopenia was 50, basically. I can give you more labs.
Okay.
So I'll start with his CBC. And I had a white blood cell of 5.9. The neutrophils were 3.9. Monocytes 1.0. Lymphocytes 0.7. Eosinophils 0.2. Hemoglobin 11.2. MCV was 89 and platelets 50.
Okay, so does the differential help you, Sherry?
In terms of the white blood cells, it sounds pretty normal to me. Maybe I'm missing something.
So the chat was going crazy,
yeah,
trying to make this HIV
eosinophilic
with odynophagia.
I see.
And
200.
Is that an adequate lymphocyte count? Yeah. But I've been fooled before at sessions like this by people who look like they have perfectly normal lymphs and then their CD4 count is like 6. So we can't rule it out. If we had very low lymphs, it would make it more likely, but it's still a possibility. Okay, so what do you think of when you see platelets of 50,000?
So when I first see thrombocytopenia, I want to make sure I rule out pseudothrombocytopenia by looking at the smear. And if it's true thrombocytopenia, I usually want to make sure there's not a do not miss diagnoses like TTP, HUS, or HIT.
Mm-hmm.
So just taking more history to rule those out. And then I will look at whether this is a chronic or acute thrombocytopenia. So if there are previous recent history or recent labs, I want to take a look. And I'll also look at other cell line, whether this is an isolated thrombocytopenia, or in this case, it looks like more bicytopenia with the anemia. And yeah, that's the workup for now. And I'll also
I'm so glad that you said that that's anemia, because sometimes we get a little jaded when we're on the wards and everybody has a hemoglobin of 11 or 12 and we don't pay attention to it. And the fact that you paid attention to it is really good. I think so. You're 100% right that it is bicytopenia. So you want to look at a smear. I like that. What else do you want to do, Sankalp?
Yeah, I think most of the things were covered by Sherry. I would also get like a reticulocyte count to see whether it's what's the cause of the normocytic anemia, whether it's like a production issue or it's like a hemolytic issue. So I think the smear would help with that, but a retic index would also help with the same. I think otherwise, I would also get like a hepatic function panel and see if there are other signs of hemolysis. But I agree with rest of the workup.
Okay, teach us, Fernand.
Okay, I hear some good thoughts from everyone. I agree that the first reflex to low platelets should be to rule out pseudothrombocytopenia. You can do it by ordering a repeat count on a citrate tube, which is a light blue top, and you can even go further and also order it on a heparin tube. Both overcome the agglutination that happens when you use EDTA. And if the other tubes do not show a higher count, this means that you have pseudothrombocytopenia. Another way is to look at the smear if you have small clumps of platelets, because normally platelets are dispersed, and this is suggestive of pseudothrombocytopenia. I agree there's a mild anemia. It is there. I do not know what's causing it. It's normocytic. We cannot rule out iron deficiency with normocytic anemia. One of the other main causes is chronic inflammation, and I always want to take a look at the kidney function, because stage 3+ kidney disease can cause anemia, one of the most common causes. With any cytopenia, I would like to take a quick look at the medications, because it's always important to know that a lot of what we do causes harm to patients' marrow or peripheral cells and can lead to cytopenia. You guys highlighted the lymphopenia. It's there. It's hard to know if it's noise or signal when we first see a patient who's acutely ill in the hospital. The most common cause of transient mild to moderate lymphopenia is acute illness, and it just resolves as the sepsis or infection or acute stress resolves. So how do you connect these cytopenias to the adenophagia and dysphagia is a curious question. Are they related, or they are two separate problems? I think we're gonna find out.
Okay, Sherry, you were going great, and I probably interrupted you because I tend to interrupt too much, and I apologize for that. Did you have other thoughts before we move on to, and if you don't have other particular thoughts about that, what other information would you like right now?
I definitely agree with everyone else. I do want to take a look at the reticular site count or order one, because I'm trying to differentiate whether this is a peripheral destruction problem where two cell lines are being destructed, or is it a bone marrow problem. And haptoglobin and LDH might be helpful, and also the total bilirubin.
You know, a previous episode we had on anemia one of our faculty members at UAB, Dr. Jory May, came on, and she reinforced what I've been taught many, many years ago, that the very first step in all anemia is to get a reticulocyte count and reticulocyte index. And her specialty is benign hematology, so I sort of trust her, and she's smarter than me, so of course I trust her. And so I love that. I love that that's what you want to do, and sort of put this into a framework. I think would be really useful. Because of the nature of this conference, we skipped the physical exam, so it's probably worthwhile to do a quick physical before we, and then go. And for the reasons that you all mentioned, we'll go ahead and get a basic metabolic panel, because you know that always makes me happy to have a basic metabolic panel, and see whether or not there might be something going on with the kidneys.
Okay, so the BMP sodium is 136, potassium is 4.2, chloride is 99, bicarb is 28, BUN is 20, creatinine is 1.0, glucose is 100, calcium is 8, albumin is 2.9. We also got LFTs, the AST, ALT.
You're gonna have to slow down, because Anne is a quasi rookie at this, so we have to give her time to type things in.
I'm writing them down too, so
Okay.
I can type it in.
You have all of them?
I do.
Okay, LFTs, AST 33, ALT 21, total bili is 2.9, direct bilirubin is, total bilirubin is 0.3, direct is 0.2, and total protein is 7.0.
Okay, so that actually gives us some stuff. And was there anything on physical exam other than the rash?
So this rash was not really substantial. There was a lot of scratch marks and some small papules here and there. It was really hard to know what is causing what, if it's a cause or consequence. Other than this, there were some white exudates inside the patient's mouth, and on auscultation there were some rhonchi in both fields.
But nothing else in particular. And I guess it looked like he'd lost weight.
Yes, he looked a little bit like on the cachectic side.
Okay. So we probably need to write some of the stuff down. Sankalp, did you catch anything in the labs that is curious?
Well, so a couple of things. In terms of the bicarb, it's a bit high. That could maybe indicate like if the patient has some COPD history or something, it could be compensation to respiratory acidosis, or it could indicate if the patient is a bit dehydrated because he's not having a good PO intake. It might be just a contraction alkalosis kind of a picture. The creatinine 1.2 kind of reassures me that it is not CKD stage 3 at least. So I don't think the anemia is because of at least a kidney-related cause. In terms of the physical exam, looking at the white plaques, I would of course ask for the patient's medicines and make sure the patient is not on any inhaled steroids, which could cause that. But I would also strongly worry about HIV, because oral candida combined with somebody presenting with odynophagia and then having bicytopenia on labs, I would strongly worry about an HIV diagnosis. So that is one thing I would definitely like to order. Yeah.
Anything else that you have to add, Sherry?
Not really. I definitely agree.
So is the protein gap worth thinking about?
Yes, I think it's elevated at
7.
Yeah, just slightly. I think we need to keep that in the back of our mind. This doesn't really sound like a myeloma presentation. I guess it could be.
There's also a small, mildly elevated anion gap, I think. The gap is 12, and with the albumin of 2.9, I think the expected is around maybe 9.
Yeah. even I can't get excited about that. And I get excited by anion gaps. I mean, if you ever presented a case to me and the patient had an anion gap, it like destroys rounds for about 15 minutes. But I don't get excited until the gap is probably 8 or 9 more than expected. You know, what the normal gap is an estimate anyway. So I'm glad you calculated and pointed that out, that it's slightly elevated, but I probably wouldn't go there just yet. And if there is a gap, you know, he's not eating, probably has a little ketosis. I'm just not going to work it up. So I guess what is your best guess? So I want both Sherry and Sankalp to get their best guess and what they want to do next. So I know we want a retic count. Let's see if we can get the retic count. Did we get a retic count index on him by any chance, Fernand?
Yeah, the absolute retic count was 65,000.
And so you're gonna have to teach
Yeah.
me what normal absolute retic count mean. Don't you have to calculate an index?
So
Yeah, do we have the
absolute-
retic index?
the absolute retic count is what we have been using. It's kind of corrected to all the variables.
Okay.
And so the clear cutoffs are basically, if you're above 120,000, you're clearly hyperproliferative. If you're less than 50, you're clearly hypoproliferative. In between is like too hard to determine, but anything between like 50 and 120 is like, you at least have some decent marrow response. It may not be the perfect one. So if you have a brisk hemolysis, like, and you're dropping your hemoglobin by 4 points over 1 day, you would expect the marrow to have a brisk reticulocytosis and an absolute count of, let's say, 180. If you have a meager count of 90, this seems like a subpar response from the marrow. But if your count is 20,000, this seems like a totally shut down marrow. So
Yeah.
it's kind of not black and white, but these are kind of the extremes, like 120 and something less than 50.
Okay. So Sankalp, now that we've established the retic count, which puts us in the never land if we're not really sure what to do with it. It's like maybe the marrow's not working that great, but we don't have that much destruction either.
Mm-hmm.
So what do you want to do next?
I'll start with an HIV test and also like Hep B and Hep C. Also, I would follow up on the peripheral smear. What it showed, like, did it show any cystocytes, or even though I don't think it's hemolysis at this point, but still to make sure there's no clumping as well. I would also get ultimately I would want an endoscopy on this guy just because he has odynophagia, dysphagia, and plaques in his mouth. That could very well be Candida esophagitis, so an endoscopy. And if they find some lesions, biopsy it. And last thing, I would also get a chest X-ray because of the rancorous sounds that he has, to make sure there's nothing else that we're missing at this point.
So this is something that's always changing. So I'm going to just throw this out there for discussion. Do you go straight to endoscopy? When with dysphagia, do you get a barium swallow first? And when do you go to endoscopy first? You want to try that one, Sherry?
I don't know.
Good, you're about to learn. That's why
Yeah.
the reason I asked that question, because this does come up. It sometimes comes up in the hospital. It often comes up in clinic that you have someone who starts to have dysphagia. Sankalp, do you have an approach to that?
Well, I'm not exactly sure, but I would feel like if I think there's a structural lesion, if I have a strong suspicion about that, which I think could be seen with a barium swallow, I might prefer that first. But I feel like, especially in cases where you suspect esophagitis, a barium swallow won't show you anything. So it's better to directly proceed with an endoscopy.
So I really like that. I think that's the way that I'm thinking right now, is that if it's pure dysphagia that that makes you think structural, and you're trying to think, is it a web, is it a stricture, is it a cancer, and a barium swallow? And you'd hate to have them put an endoscope down without knowing where the obstruction is. But I think the point that you're making, that because it's odynophagia, we're really worried about, could it be herpes, could it be Candida esophagitis? And so it's the odynophagia that drives us to at least talk to GI and see if they're willing to do an endoscopy. But they probably want to know the CD4 count and the HIV status first.
And yeah, I'm sorry to interrupt you. One more thing, like a caveat that I just remembered from like the board studies, was that if the patient is HIV positive, and since the patient has those white plaques in his mouth that could be Candida, they often recommend empiric treatment with fluconazole first before actually endoscoping and actually biopsying it. So that might be a possibility if the patient is HIV positive.
Yeah, I think that's great. So Travis asked this question. I think it's worth discussing this because this does come up both in the hospital and outpatient. If the barium swallow shows a structural problem, do you follow up with an EGD? You often do, but it helps the endoscopist to know where they're going to find the obstruction and be a little bit more careful as they're putting the scope down. That's what I was taught. Since I'm not a gastroenterologist and I've never done an endoscopy, I'm just telling you what the way that I understood it in the workup. And I have made diagnoses just with the barium swallow before. Okay, so Fernand, they really want an HIV test and a CD4.
Okay, let me first give you the smear and the EGD, because that would kind of give you more information about the cytopenias and the odynophagia. So the EGD showed extensive esophageal plaques that were brushed, and the differential was Candida or malignancy, and the cytology came back as negative for malignancy. The cytology days later was positive for some yeast. As for the smear showed large platelets, no clumping, and it showed some fragmented cells here and there, and some acanthocytes and some teardrops. No substantially predominant type of peripheral smear. No massive amount of fragmented cells.
Okay.
We also had a CAT scan and a chest X-ray. So I can give you the CAT scan. So the CAT scan showed extensive bilateral interstitial infiltrates and parenchymal lung scarring. There are some scattered bilateral micronodules, tree-embodied nodularity, and patchy opacities, compatible with small airway disease. The esophagus appeared as thick wall with some hyperenhancement, suggestive of possible esophagitis.
In the physical exam, what kind of an oxygen saturation did he have?
He was not on oxygen and he was starting normal.
Okay. Okay, Sherry, you wanted the peripheral smear, so you got the peripheral smear. Now what do you want to do with it?
So the smear shows some large platelet without clumping, meaning that the thrombocytopenia is real. And large platelet, I usually think about like autoimmune mediated, like ITP, that can cause large platelet. So, but it's very non-specific, so I'm not sure what to do with it right now. And with the fragmented cells and all kinds of no massive amount of fragmented cells, that I'm not exactly sure what it can be. I have seen some weird shaped cells with patients with liver disease, but I don't think this patient has any liver disease or renal dysfunction. I'm thinking about nutritional deficiency might make the cells more fragile, but I don't think this explains everything here. So at least this smear is reassuring that there's no schistocyte that's indicating TTP or HUS.
So
That's
has
my
your
thought for the smear.
Has this changed your differential in any way?
Basically rule out TTP or HUS.
Okay.
In the large cells, I think it might make HIV more likely. I think in patients with HIV with thrombocytopenia, it can be mediated through ITP. So that's a possibility.
So Sandkalp, let's say this patient was admitted to you. Would you have done all these tests, or would you have gone? Would you have done them in a different order? So this is, remember, we're using the retrospectoscope, so we're going to be smarter than the team who took care of them, just because we're looking at it backwards and the way that it's being presented to us. So this is not a criticism of how they worked it up, but with the information that Fernand gave you, would you have done all these things?
I would have started with an HIV first, just because we have significant concern for that based on the labs and his presentation. I would have definitely gotten the chest X-ray because we had those findings of bronchi in both of his lungs, and so I would definitely have gotten that. And if the X-ray was positive for findings, I would have gone forward with the CT scan as well. And the reason for that is since he might just be an immunocompromised patient who has Candida in his esophagus. There might be some underlying other etiologies as well. Based on the CT scan, I would think that this also might be some underlying interstitial lung disease which the patient has. We do not know a lot about the patient's history, so we can't really comment on that. But yeah, based on the labs that we got, I would have gotten all of these as well. Just I would have done the HIV first and then the X-ray first, followed by a CT scan if needed.
So the one thing we didn't get is a behavioral history. So this is something that CP Solvers talks about a lot. We talk about social history, and we actually did get we got some social history, although we don't know what work he did.
Yeah.
But we didn't particularly get a sexual history. We have no illicit drugs. So if it's no illicit drugs, we assume he's not using IV drugs. A sexual history might be worthwhile in this guy. Now, it's sort of a moot point because we're going to get an HIV and we're going to get a CD4. So if he has HIV, how he got HIV, really has not a lot of impact. Although, if he's MSM, then that in some ways that changes some of the other testing we're going to do. So let's play the assumption game. Let's assume we get back a low CD4. What other tests other than HIV are you interested in a man who first shows up and you're making a new diagnosis?
So I would also get Hep B, Hep C. If there is some history of unprotected sexual activity, I would also get the typical STI panel, gonorrhea, chlamydia. And I think that's it. I'll get HIV quant and try to figure out what genotype or if it's HIV1 or HIV2 and stuff like that.
Yeah.
I think that's it.
I was forgetting this for some time, so I'm picking on myself. Every time that you think about HIV, you have to think about syphilis in 2021, and because syphilis is really increasing. And what about this? So now let's assume we end up with HIV. Does that change how we're going to look at these infiltrates on a CT?
So typically, of course, the most common, a very common cause of pneumonia in HIV patients is PCP. Usually, it presents with bilateral ground glass opacities, and patients usually are at least more sicker, at least have some oxygen requirement. So that would still be a possibility. Other atypical organisms that could cause these infiltrates could be some form of aspergillosis, or if you think about non-infectious etiology, I would still, based on the CT findings, think of interstitial lung disease. I think those are my thoughts for now.
I would put MAC and TB
Yeah, and MAC as well. Yes.
as a possibility. Okay, Fernand, how are we doing?
Yeah, I like all your ideas. I mean, I would not forget in the differential for the lung lesions that look like this. COVID, obviously, but this feels less acute. And in subacute or chronic setting, I would think of the endemic mycosis, such as histoblasto
Mhm.
and coccidio. Mainly histoplasmosis can manifest like this. And God knows if the skin lesions could be related to this. So this is always something you want to think about if you have skin lesions with a pneumonia. What connects candida in the mouth and the esophagus with cytopenias and subacute pneumonia? We got the tests you want. His HIV-1 was positive. His CD4 count was 6. When I saw the patient and I was talking to my attending, I said, like, there is no way this patient does not have HIV. Like, I could not explain things otherwise. It just fit everything. And eventually, his sputum was positive for pneumocystis, and he had PJP. So count the opportunistic infections he had. He had a mild CMV viremia. He had PJP. He had the candidiasis in the esophagus, and a very profound immunosuppression.
So let's talk about PJP for a second, because this is something that was very common, 20, 30 years ago, is less common for us to see it now. And so, but we do see it. Thinking back at looking at him, so the last patient that I diagnosed with PJP, I pretty much diagnosed by looking at the patient, and he was so emaciated that the first thing that came to mind is this is HIV and this is PJP. Did he have that look, Fernand, in retrospect?
Not really. Didn't
Not
look
that bad?
that wasted.
Okay.
Yeah.
So here's the question, Sherry. How are we? So he is not hypoxic. How are we going to treat his PJP?
Are we going to treat with the antibiotic? I forgot. Is it azithromycin? No.
So I'm so glad that you're participating, because you probably have never seen this before. And when you haven't seen it before, it's hard to remember all this stuff. Once you see it, it's easy to remember. But it's better to learn this as a fourth-year student than have to learn it as an intern. It's better to know it before you're an intern. So Sankalp, how are you going to treat the PJP?
I would prefer to start with Bactrim, which is the drug of choice. Typically, if there are no contraindications, and to make sure that the patient is not allergic to Bactrim. But yeah, that's the top choice. The fact that patient is not on any oxygen means that his PO2 is definitely more than 80. So he doesn't meet the criteria for giving any steroids at this point. It's usually if his PO2 is less than 55. So I would hold off on that. I would just give him Bactrim and monitor.
So I once did that to a patient and threw them into full-blown crisis with the normal O2, the last person that I diagnosed with PJP. So I talked to Mike Sag, who is one of the stars of the HIV treatment over the last 30 years, who's one of our colleagues. And he points out that the guidelines say you don't give steroids unless the PO2 is less than 55 or the saturation is less than 90, I think.
88, yeah.
88, okay. But he points out that the study, it's just because the study was done in those patients that you see plenty of people who you give some sulfamethoxazole trimethoprim to, who have PJP, who look like they have a good PO2, and then they crash. And my patient crashed. And so I presented it to Mike and said, you really should have started the steroids right away. So it's a little controversial, but just keep in the back of your mind. Now the steroids might make the candida a little worse in the short run, but he would argue, this is what Mike Sag argues. I don't know if you've heard this from him before, Ann, but he argues that you should always use steroids when you initiate treatment for PJP, and that's not what the guidelines say. That's what his clinical experience tells him. Had you ever heard that before, Fernand?
I'm sorry.
Had you ever heard anybody talk about that before?
I was I was reading Twitter. So what was the thought?
So once you start antibiotics for PJP, he argues that you always give them steroids. And Travis says that he was taught that also. That regardless of those two, if it's a patient who's virgin to antibiotics for PJP, the risk, and what's the name of the thing where you kill the cells too fast?
Iris.
Yeah. The risk of iris is so great that you should go ahead and when you initiate Bactrim, start steroids, because and since you missed it, and hopefully you're finding something good on Twitter, since you missed it, what he says is the only reason we have those oxygen criteria is because that's who the original study was done in. Nobody did the study in people who had normal O2s. But he sees plenty of people who got iris who started out with normal O2s.
Yeah, I see the point. I think iris, we're at high risk of developing iris if we start ART, because when we start ART, we're gonna have more immune system to react. I can still imagine with a compromised immune system, you can still have iris, and then maybe pull the steroid card. I've seen different practices from ID attending. I've even seen ID attending give all patients with non-HIV PJP, such as leukemic patients, steroids, saying like we don't have much to lose. So yeah, people have been extrapolating beyond these studies, and I do not know if we'll ever have any significant data in these entities, but it doesn't seem like in HIV patients, we will be hurting patients by giving steroids. We may not be benefiting them. In the non-HIV population, it's questionable.
Right.
There were some data that it might be harmful. It's hard to know.
Anyway, that's something for all the students, interns, and residents to think about. If you diagnose PJP, if you decide to just give them trimethoprim sulfa, just remember that it is a possibility they're going to crash. And I did it. I crashed a patient, and it's not fun to have to call up the ICU and say the patient crashed when I put him on antibiotics, and I didn't give him steroids, and that was not a fun conversation. So, Fernand, why don't you go over what the main points that you wanted everybody to get out of this case? Because I think, first of all, Sherry and Sankalp have been great. And as usual, the chat is on fire. But since you brought us this case, and this was really worthwhile to think through it, why don't you give us your big take-home points?
Yeah, I think it's a very rich case. It's pretty simple, but it also reminds us like of the breadth of complications we can have from HIV, which is a fascinating infection. So I think always try to connect the dots and try to come up with a unifying diagnosis. And here the only unifying diagnosis was HIV. So think of HIV when you have cytopenias, persistent unexplained cytopenias. Think of it when you have an ITP, because HIV can cause ITP, thrombocytopenia that's isolated, always, and it's not explained by other factors. Always look for HIV. Always think of HIV when you have esophageal candidiasis, and think of esophageal candidiasis when you have adenophagia, dysphagia, plus a clear thrush in the mouth. A subacute to chronic pneumonia, some people would argue also order HIV, because any diffuse histoplasmosis or blastomycosis or PJP can have underlying HIV. What else? Always think of HIV when you have a persistent lymphopenia. The good corollary would be an absolute lymphocyte count of 1.2 correlating with CD4 of 200. The most common cause of transient lymphopenia is acute illness. COVID can cause transient lymphopenia. Sepsis can cause it. Some drugs can do it. But persistent lymphopenia is always concerning for immunosuppression. Always be careful when you start treating PJP. Gold standard is Bactrim. It's IV if the patient is really sick, oral if the patient is less sick than usual. Think of steroids when patient is hypoxic. And always be careful when patients have cytopenias, because Bactrim will worsen cytopenias when you start it and when you give it over prolonged periods of time. Your alternative would be primaquine and clindamycin, which is not as good as Bactrim if you develop worsening of your thrombocytopenias. So these would be cases where I would test for HIV. And that's what I have.
Good. Sherry, thank you so much for being a great discussant. What are your big take-home points?
Thank you for this case. I learned a lot. This is exactly my favorite and least favorite subject. So in combination, I really love it. So thank you. I think for me, I learned about the workup or when to use EGD versus barium swallow. So if the patients only have like pure dysphagia, we can consider barium swallow. And there's also the concern that if the barium swallow might provide some insight into, like before you do a EGD, you can like have a look of the structure around, so it may makes the EGD more safe for patients. And if the patient have adenophagia, you probably want to go to do EGD eventually. And also in the beginning of the case, when I was looking at persistent lymphocytopenia, HIV was not on my radar. So that's something I need to keep in mind the next time I see, even though it's a mild lymphopenia.
That's great. And as Robbie and Reza would say on Clinical Problem Solvers, we're so proud of you for saying what you didn't know, because that gave you a chance to learn something. And if you learn something, then every day that you learn something is a great day. And I can say that after learning a lot for the last almost 50 years. It'll be 50 years next, another couple of years. Sankalp, what are your big take homes?
Yeah, this was like a really interesting case. And I think one of the first things I learned was in the evaluation of pseudothrombocytopenia, trying to send like a citrate bulb and see if it replicates in that as well. So that is something I did not know, and I might practice that in the future. Apart from that, of course, using steroids in PJP, I just knew the guidelines, and I would have strongly advocated for that if we had a case on the floor like this. But from your experience, I think I would definitely consider steroids earlier if I feel that there is a strong potential for the patient to crash. So those two are like really the take-home points for me that I'll definitely make sure that I remember.
Anne?
Yes. Just take home points.
Yeah.
Yeah, I think that just thinking through sort of who your patient is and When you see weight loss, just thinking about chronic illness. I will say too that I think that going back to that protein gap, chronic inflammatory disorders do cause protein gaps. And so I think that there was a little hidden clue there as well. And then I also learned something about the steroids as well. I had not seen steroids used up front. And so that was something else I learned as well.
Yeah, I think just something to keep in the back of your mind. I want to thank Fernand for bringing us a case that trying to figure out what the labs were in the context of the rest of the case. I think most people were getting there fairly quickly, but I think understanding how we got there and understanding the reasoning behind it, I thought it was a great discussion, and that's how we get better at making diagnoses, is by being able to think through that stuff and understanding how people think through it. I think the discussion of how to evaluate the thrombocytopenia was really outstanding. So thank you, Fernand, for bringing the case, and thanks to everyone for coming.
All right, thank you.
Thank you.